السلام عليكم طلاب، رحب بكم بالجروبات المتبقية، وراح يكون لنا لقاء خلال هاي المحاضرات الإلكترونية حتى أنطيكم الماسكولوسكليتال سيستم. حاولت أن أبسط السلايدات وأن نكون نبدي بعض السلايدات عن الاناتومي for refreshment or your knowledge about the anatomy of the bone, and later on we will try to discuss the pathology in titles which are very important, and try to reach the diagnosis as much as possible, because there are in fact many entities in this system. So please try to concentrate on the image, on the main description for each lesion, and we will discuss any things later on. In this diagram we can see the normal anatomical landmarks for the long bone, the site of the epiphysis at both ends of the long bone, and the site of the metaphysis just after the epiphysis, and in the midway we can see the diaphysis. Also we can detect the area of the cortex, which is outside on the surface of the bone, and we call it compact bone. Also in the mid part of the bone we have a space which is called marrow space, or the medulla. The most important thing also is the growth cartilage, which is just the area between the epiphysis and metaphysis, and it is an important site for the knowing if the skeleton is mature or not. And lastly we have the articular cartilage, which is covering the articular surface of the bones. Examples of the plain X-ray of the right hand, we can see the metacarpal bones. We can see on the right image the part of the bones which show the cortex, which is very dense as compared to the medulla in the middle. So the medulla, it is the marrow and it is low dense, while the cortex on both sides is hyper dense and it is denser than the medulla. What about the normal anatomy? You can see that from distal to the proximal part, we can show in this image on the left side the head of the metacarpal, the part of the neck, the shaft and the base. So this is in general normal anatomy. In this example we can see the lateral X-ray of the knee joint, the normal anatomy. In green color we can see the epiphysis, which is near the articular surface of the knee joint. In red color we can see the metaphysis, and in yellow color we can see the diaphysis, while the white line, it represents the growth plate, which is fused in this type of X-ray. It is very important to try to describe the features of the pathology in the X-ray. So here we have multiple radiological signs that can help us in the diagnosis or description of at least an X-ray or a pathology. First of all, we should check the bone density. If it is focal, that means it is localized to certain part of the bone, or if it is diffuse, that means involving whole parts of the bone or multiple bones. You should also notice if the density is high or low. I mean, if there is any decrease in the bone density, we can describe it as osteolytic, or it could be increased and describe it as osteogenic. Sometimes we have mixture of both of them, and we call there is a mixed component of both osteolytic and osteogenic lesion. Important feature also to look that if there is any associated periosteal thickening or reaction seen in the film. Also, you should try to check the growth of the pathology, if there is any features of the benign or of the malignant tumor, according to the transitional zone, as we will mention later on. You should also check the trabeculation of the bone, which means the bony component or the bone matrix, and the shape of the bone, any deformity, any associated fracture line, and also the associated condition of the soft tissue surrounding the bone, because sometimes we can detect soft tissue swelling or calcification or soft tissue mass. And as we know, the age of the patient is very important, so we should check if the epiphysis is fused or not to know if the age is mature or immature skeleton. In this image showing that there are different pathologies of bone can be seen in different sides of the bone. And also we can see that the image on the right side, it is a mature skeleton. Why? Because the epiphyseal plate is fused. While on the left side we can see that there is X-ray, or it is a bone of an immature skeleton because there is no fusion of epiphysis. These are examples for bone pathology, and we should know how we can describe the transitional zone. transitional zone في البداية إذا نحب نوصف transitional zone نحاول أن نرسم حدود الليجن، يعني نتخيل أنه إحنا بدنا نرسم حدود الليجن بالقلم. فإذا كان من السهل أن نرسم حدود الليجن فهذا معناها أنه الليجن more goes with benign and regular outline. بينما إذا كان من الصعوبة أن نرسم حدود الليجن فهاي معناها أنه هي أقرب إلى أن يكون الترانزيشنال زون wide and أقرب إلى malignancy. So these are examples. The red arrow show us a benign lesion, while the green arrow it show us a malignant lesion. So the narrow zone of transition, as seen in this example, it shows osteolytic lesion at the lower part of tibia with well-defined margins. إذا تلاحظون ممكن أن نرسم أطراف الليجن بسهولة. While in the next image, which is demarcated by the green arrow, we can see that just area of low bone density involving the medulla and part of the cortex with no obvious boundaries, or we cannot judge where is the normal and the abnormal bone. So ببساطة احنا ما ممكن أن نرسم أطراف الليجن بالقلم. So it means that this is aggressive lesion or wide zone of transition. Periosteal reaction. Periosteal reaction, it means cortical thickening. But there are types of periosteal reaction. So it could be solid periosteal reaction, as we see in the first image. The white area, it represents a cortical thickening, while the other images are showing more aggressive features of periosteal reactions. As we can see in the lamellated periosteal reaction, there are multiple layers, so we can see multiple white lines seen at the cortex, while in the speculated we can see multiple small white lines that are seen in vertical orientation to the cortex. So we call it speculated, and sometimes we call them sun ray speculation. Lastly, we have an example for the Codman Triangle, in which we can see only part of white lines that seen overlying the cortex and forming a triangular shape, and we call them Codman triangles. So the lamellated, the speculated, the Codman periosteal reaction represents aggressive or malignant type of periosteal reaction, while in the first one, the white one, we call it the benign or the solid periosteal reaction. اوكي طلاب، تلاحظون بهذا السلايد عندنا 3 انواع من البريوستيال رياكشن. بالصورة الاولى نلاحظ انه السهم الاصفر يشير الى البريوستيال رياكشن اللي هو single layer, solid layer, more goes with benign. فنلاحظ on both sides of the cortex there is a regular white or dense line, we call it the periosteal reaction. بالنسبة للإيمج اللي هي بالوسط, we can see that the green arrow is marking on multiple layers. So these multiple layers are seen on both sides of the cortex, but more clear on this side. That is represent a periosteal reaction of more aggressive pathology. يعني كل ما زادت الخطوط نفكر أنه الليجن هو more goes with aggressive pathology. Lastly, the last image, نلاحظ أنه البون is surrounded by area of soft tissue swelling, وهذا مثال على أنه هناك بعض التيومرز ممكن أن تكون surrounded by soft tissue swelling. لكن النقطة اللي نريد نركز عليها بهذا الفيلم هو مثل ما تلاحظون الأسهم البيضاء اللي هي تأشر لنا على السبيكيولز أو يسموها البريوستيال رياكشن اللي هو بشكل vertical lines over the cortex. We call it sun ray speculation. Also, what we can see in this film is the red spot, which represents the Codman Triangle. This is a shape of triangular density seen sometimes in aggressive tumors in association with the bony speculation. So this represents very aggressive tumor that is showing the Codman Triangle and the sunrise speculation, which is more going to be seen in Osteosarcoma. Here another example we can see in the image A, the solid periosteal reaction. In the image B, we can see just very thin layer seen overlying the cortex. This is also an example for simple or benign periosteal reaction. So A and B, it is simple, while image C, it's the multi-layering, and lastly image D, we can see a very fine sunray speculation and early Codman Triangle seen in the upper tibia. Now we will go on multiple pathologies, and we will take first of all example for the malignant or aggressive bony tumor, which is called Osteosarcoma. Osteosarcoma is usually seen in the metaphysis of the long bones. As you can see here, the lesion is arise from the metaphysis with involvement of the cortex and the soft tissue surrounding area. The density of the bone is mixed density and seen on the right sided picture, which show osteolytic and osteogenic features with presence of Codman Triangle, while on the left side the image is show advanced osteosarcoma, which causing soft tissue calcification and swelling together with abnormal bone density. In this plain X-ray of the left humerus, we can see that there is abnormal periosteal reaction. As you see in the image on the right side, the arrow is marking to the site of the periosteal reaction. This type of periosteal reaction, as you see, it is multi-layered. So it is which type? It is the lamellated periosteal reaction. So we should think of aggressive bone lesion. This type of periosteal reaction is seen in the metaphysis and diaphysis. So this is mostly diagnostic for Ewing sarcoma, and there is a name for this type of periosteal reaction. We call it onion peel appearance. In fact, this is the early stage of Ewing sarcoma, which is a malignant bone tumor, and this can be, of course, proceed to late stage and maybe even result in soft tissue calcification. As we can see on the other image, this round green area, it represents the involvement of the soft tissue. So the density of the bone is not clearly seen, and the surrounding soft tissue part of the muscle, it appears very dense. So this is due to the involvement of the soft tissue area surrounding the bone in advanced case of Ewing sarcoma. We can put in the late stage differentiate diagnosis of osteosarcoma because of the very large soft tissue mass. Another type of bone tumor is that which arises from the cartilage, and the example is Chondrosarcoma. Usually in this slide we can see a large mass, usually in the soft tissue surrounding the bone. Because it originates mainly from the cartilage, it usually shows the type of calcification which is specific for cartilage. Here you can see there is mixed density, low and high dense in the right hip joint. This mixed density is appear like popcorn or just area of ring and arcs calcification. This is diagnostic for Chondrosarcoma calcification, usually seen in the 4th and 5th decade of life and very large at the time of the diagnosis. مثال على البناين tumor عندنا Osteochondroma. From the name Osteochondroma, it means the bone and cartilage. Osteo for the bone, chondroma for the cartilage. So ايش نتوقع؟ انه نشوف two mixture of density. الدنس اكثر طبعا هو راح يمثل البون اللي مثل ما نشوف بالصورة it is just protrusion of dense bone similar to the cortex، بينما اللو dense bone يمثل لنا الكارتليج اللي هو يكون just covering the bone. So in the image on the left we can see dense bone surrounded by a low dense area which is the cartilage. This is the exostosis or benign osteochondroma. This type of tumor is usually benign, although sometimes there are changes in the cartilage that may be more going with malignancy. مثال آخر على الأوستيوكوندروما الإيميج اللي هنشوفها على اليمين، نلاحظ أنه الأسهم الموجودة فيها تشير إلى osteochondroma. Osteochondroma, which is seen in the knee joint here, one is seen just in the upper tibia and projected away from the knee joint, while the other is seen in between the tibia and fibula. It is widened or causing widening the space in between the tibia and fibula. If we have two or more exostosis or osteochondroma, it is called diaphyseal achalasia. يعني من نشوفها multiple نسمي تسمية diaphyseal achalasia. طبعا إذا قلنا exostosis أو multiple osteochondromas, it is the same. So we should check for the protrusion of the bone. لازم نشوف أنه أكو protrusion of the bone، ولازم يكون هذا ال protrusion of the bone away from the knee joint. So the direction should be far away from the knee joint, and we can sometimes detect the cartilage overlying the exostosis, which is seen just like this image as low density area surrounding the bone. This plain X-ray is taken for the left wrist. You can see that there is abnormal bone density seen in the distal end of the radius. There is expansile low dense lesion is seen. This type of lesion is called giant cell tumor. How we can differentiate or we can diagnose giant cell tumor? The most important thing is seen just at the end of the long bones, subarticular، يعني كلش قريب من حافة الارticular surface of the long bone. And also it should be seen after fusion of the epiphysis. So it should be seen in the mature skeleton. Usually it is benign, but it can be locally aggressive and show expansion. Sometimes we can see pathological fracture due to any trauma. So here in the left image you can see the green arrow marking the area of discontinuity in the cortex. This is the site of the fracture. So this is a case of giant cell tumor of the radius with associated pathological fracture. In osteoma, which is also a benign tumor and seen in the young children or adolescents, we can see that the lesion is made usually or typically from a radiolucent oval lesion that is seen in the first image in the CT scan. This is oval radiolucent lesion that is surrounded by sclerotic reaction in the bone. So this is the classical appearance, and sometimes we can see inside the osteolytic lesion a very small dense spot as seen here in the right image. So the lesion is osteoma. This osteolytic lesion or oval low dense lesion is called the nidus, and sometimes this nidus containing small area or spot of calcification as shown in the right image. So the osteoma is a benign lesion made from the nidus and surrounded by a thick sclerotic bone. Sometimes we can see only the sclerotic bone, and sometimes we can see only the osteolytic oval lesion, and even we can see both of them together in other cases. Other examples for osteoma, you can see in the left image only sclerosis in the cortex, which is seen just marked by the green arrow. Here this type of osteoma is sclerotic. Once we want to do CT scan, it will show us more details. As we can see in the image on the right side, this is axial CT scan showing the tibia and the fibula. The abnormality is in the cortex of the tibia, as you can show the red arrow here showing us a well-defined osteolytic lesion in the cortex. So the osteoma is in the cortex, and you can see inside the cortex this osteolytic lesion that is called the nidus. So the whole osteolytic lesion is called the nidus. And sometimes we can see ossification inside the nidus, very sometimes occasionally detected in CT scan. If we do an isotope scan for osteoma, we can see that there is uptake in the isotope scan. So the uptake is seen as a blacky area in the right femur. In the mid part you can see there is uptake in form that is seen near the green arrow in both images. This is occur because of the nidus of the osteoma that contain vascularized tissue, making this is positive in isotope scan. A common benign lesion that is usually seen in the sinuses is called the osteoma. Usually it is seen as a dense structure in the X-ray or in the CT scan. Here in this example we can see that there is a round dense lesion seen in the X-ray on the right side, showing well-defined margins, and it is just marked by the red arrow. It is located in the right frontal sinus. The same example is taken, but in CT scan we can see in this axial CT scan of bone window that there is a well-defined dense structure noted in the right frontal sinus. This is represent a benign bony osteoma that is commonly seen in the sinus. Plain X-ray of the right humerus taken for child. You can see that there is well-defined osteolytic or low-dense lesion in the metaphysis of the right humerus with very mild expansion and associated pathological fracture as seen. The cortex on both sides are not continuous, and the lesion is well-defined, showing endosteal thin margins and no calcification, no periosseal reaction seen. Another example for the solitary bone cyst, as shown in this image, there is a well-defined osteolytic lesion seen in the metaphysis of the right humerus, and the lesion is associated with a pathological fracture as is marked by the green arrow. Also, there is an important sign that's seen in this film, in which there is a dense bone or dense fragment of bone seen in the dependent parts of the lesion. This is called full fragment sign, and it is formed because part of the cortical bone is broken and then pass or descend through the fluid of the cyst inside the lesion and forming this sign. So this is a specific sign for solitary or unicameral bone cyst. In this X-ray, we can see the right humerus is abnormal. There is a large expansile osteolytic lesion seen in the metaphysis of the right humerus, marked by the green star, with associated mild sclerotic margins, and this bone lesion is seen just in the area away from the articular surface and in immature skeletons, so it is seen just before the fusion of the epiphysis. Also, on the image on the right side, we can see MRI study done for the lesion, and we can see multiple high signal intensity areas with fluid levels that represent vascular spaces within this lesion. So, in fact, this lesion is a cyst that containing vascular spaces, and that's why it appears as a high signal intensity in the MRI. And this type named as the aneurysmal bone cyst. أهم نقطة في تفريق الأنيوريزمال بون cyst عن الجاينت سيل تيومر أنه تكون موجودة في الإماتور سكيلتون, يعني mostly in the children or in the adolescents, and it's usually away from the articular surface and appear expansile with mild sclerotic margins and multiple fluid or hemorrhagic fluid levels seen on MRI study. In this slide, we can see that there is another type of benign tumor which could arise from the fibrous tissue. We call it the fibrous cortical defect. We can describe the lesion as seen in the left image as a very thin radiolucent or osteolytic lesion or area in the cortex of the lower tibia. On the right side, there is an image for the same lesion but in CT scan. We can see that the defect is very clear, seen in the cortex of the tibia. This represents a fibrous cortical defect as it is demarcated by the green arrows. Another common fibrous benign tumor, we call it non-ossifying fibroma. You can see the image on the left side describing a benign tumor in the lower tibia. Osteolytic, well-defined, sclerotic margin bone lesion seen in the lower tibia. We call it non-ossifying fibroma. It is susceptible to fracture. As you can see in the next image on the right side, there is a fracture line oblique involving the osteolytic lesions that is seen in the lower tibia. So this represents an area of pathological fracture seen in a patient having non-ossifying fibroma. Hemangioma of the vertebra is a common benign tumor that affecting the vertebral body, and usually can be seen in the X-ray as a vertical striation. You can see the plain X-ray of this vertebra showing multiple vertical dense lines involving the body of the vertebra, as you can see in this image on the left side. This represents the hemangioma in the X-ray of L3 vertebra, while on the right side we have CT scan that is taken for the same vertebra and showing multiple dense spots seen in this body of the vertebra. In fact, this represents the polka dot sign that is caused by the striation of the vertebra when they are examined by CT scan. Here in this slide we can see the MRI of the hemangioma. You can see abnormal signal intensity of T8 vertebral body as high signal intensity on both T1 and T2 MRI study. Of course, this is a sagittal view and you can see the abnormal vertebra well delineated in MRI. So you can note that the image on the left is the T1 because the CSF is low signal, and the image on the right is T2 because the CSF space is high signal intensity. Osteomyelitis is the infection of the bone. We can notice that in the early films there may be very minimal changes in the X-ray, or there may be even normal X-ray, while later on there will be changes can be seen in the bone as a decreased area of the bone density and later on destructive bony lesion. So we can see all these in the following films. In the image A there will be very minimal changes and even the X-ray seems to be nearly normal. In image B there is a progressive bone destruction which is noted as osteolytic areas in the lower end of radius and ulnar, while in the advanced osteomyelitis the whole part of the tibia in the lower part mainly and in the fibula there will be severe bony changes involving the destruction of the cortex and part of the medulla, with an evidence of sequestrum, which is the dead bone which is appear very dense and reaching the surface. And in the last image you can see the area of the sequestrum is seen overlying the area of the cortex, and this represents the complication of osteomyelitis. Another example for the osteomyelitis is the osteomyelitis of the tibia, which is noted here, involving the mid and lower part of tibia, showing cortex erosion or destruction and involvement of the medulla also, with destructive osteolytic lesion mainly involving this part of the bone, representing the osteomyelitis. In this image we can see on the right side is the plain X-ray of thoracic spine, and on both sides we can see a paraspinal soft tissue density, while on the left side we can see a coronal MRI, and also there is a paraspinal soft tissue density with abnormality in the thoracic vertebra and the intervertebral disc space. In fact, this is a diagnosis of the most common infection in the thoracic spine, which is the spinal tuberculosis. This plain X-ray is taken for the whole body of neonate, which is in fact the stillborn neonate. So, what we can see in this image is the generalized decrease in the bone density, with abnormality mainly seen in the upper limbs and lower limbs, also in the form of multiple fractures, different in size and in areas which are appear to be cystic in nature, and even the ribs to some extent are involved. This is an important congenital abnormality which is called Osteogenesis Imperfecta, which is a genetic abnormality that results in the abnormal formation of skeleton. In this plain X-ray, which is taken for the chest, upper abdomen and for the pelvis, we can see that the general bone density is abnormal because it is uniformly increased in density, and this abnormality is due to the abnormal bone formation in a disease called osteopetrosis. So, opposite to Caffi disease in a neonate, we have another congenital abnormality which is showing an increase in bone density and usually associated with extramedullary hematopoiesis abnormality like enlarged spleen. Plain X-ray of a child having ricket. One of the most important abnormality in the bone in children is the ricket. We can usually diagnose this in plain X-ray of the wrist joint or plain X-ray of the knee joint. So this example, in the wrist joint, what we can see? We can see that there is abnormal density seen in the ends of lower bones, which is appear as curvature in the end of the radius and ulna, and this is called cupping and splaying of the lower end of bones. Also we can see that there is abnormal bony matrix in the lower part of the bones, which is seen sometimes and we call it fraying. So the green arrow is demarcated here for the cupping and splaying, while the red star is demarcated here for the area of fraying of the bones. Also, widening of the epiphyseal plates is very important as part of the criteria in rickets. Another sign which is important in rickets and can be seen in the thoracic radiology is the ricket rosary. This is abnormal enlargement in the area of the costochondral cartilage that is seen as in this image. On the left side there is a lateral X-ray of the chest. We can see anteriorly abnormal expansion in the area of the junction between the ribs and the sternum. We call it ricket rosary as shown here. بالنسبة للأدلت we have osteomalacia, which represented in adults by the loser zone. So these loser zone appear as area of transverse incomplete lucent line that is seen at different parts of the long bones, could be seen at the neck of the femur medially or could be seen at the long bone cortex. So this is called loser zone. Sometimes these osteolytic or radiolucent lines can have changes like sclerosis, and this is usually seen to be related to the treatment of the osteomalacia. We have plain X-ray of the pelvis. We can see that the left neck of femur is abnormal because there is a thin lucent area that is surrounded by area of sclerosis. This is represented the site of the loser zone, which is seen in patient of osteomalacia after receiving treatment. This slide we have a radiological sign which is called codfish spine appearance. This is related to the abnormal spine which is seen in both X-ray on the right side and CT scan on the left side, usually seen in osteoporosis, or it could be seen due to other bone abnormality or systemic diseases. So what we can see, the shape of the vertebra is abnormal. Normally it should be rectangular in appearance, while here we can see that there is a concavity in the upper end plate and in the lower end plate, just as demarcated by the green arrows, and this will make the space or the disc space in between the vertebra looks larger than it seems to be. So this is the diagnosis of codfish spine radiology. In fact, osteoporosis is abnormality that is related to the bone matrix. So the number of the trabeculation, it will become less than the normal bone. As you can see here, the normal bone is seen above, the abnormal or osteoporotic bone appears below, that the number of the trabeculation is less. and this is responsible for the generalized decrease in the bone density. Usually, we study the osteoporosis in a DEXA scan. DEXA scan, it is a dual energy X-ray absorptiometry, which is very effective for studying the generalized bone density and lastly diagnosis of osteoporosis. Plain X-ray here is taken for the thoracic spine in postmenopausal women. On the left side we can see that there is generalized decrease in the bone density in the thoracic spine, so as the end plate appear slightly denser than the vertebral body. So this happens because of the postmenopausal changes that affect the bone density. If still this continues and progress more and more, so if there is no treatment or no replacement, this may be advanced to make the vertebra in abnormal shape. So it may result in wedging of vertebra and lastly kyphosis, which is seen on the right side as you can detect the deformity in the thoracic spine. So this represents thoracic vertebral body osteoporosis. Also, we have examples for the metastasis to the skeleton. We have X-ray of the pelvis and upper femur, AP view showing multiple well-defined osteolytic lesions, different sizes, seen involving the sacrum, the pelvis, the femurs, and pubic bones. This is osteolytic metastasis, which is a common, can be seen in breast carcinoma or in other types of metastasis. Sometimes the metastasis can be appear as a dense bones. So in this example we can see that the vertebra and the pelvis and even the ribs show increased or generalized increase in the bone density, and this is represent a case of metastasis from CA prostate that result into diffuse or extensive sclerosis of the ribs, clavicles, and pelvis. So metastasis can be appear osteolytic or osteogenic, or it could be even mixed, both of them, and sometimes single body vertebra metastasis is seen, which is called ivory vertebra. As seen in this plain X-ray, we can see that the single vertebra, which is noted here as very dense vertebral body. This represents metastasis. Isotope scan is one of the most important imaging modality that can help us. As you can see in this image of isotope, there is abnormal intake in the thoracic vertebral body and in both iliac bones, especially the right one, and even part of the femur. This patient may have a metastasis from other primary elsewhere in the body. More advanced imaging, we call it PET-CT scan. This will help us for the diagnosis also for bone metastasis, as there is uptake in the abnormal part of the body that contain the malignancy. You can see in this patient with breast cancer, there is a high uptake, which is seen in the circle on both coronal and sagittal view. The coronal view on the right side, the sagittal section on the left side. So this represents metastasis. Multiple myeloma is a common malignant bone tumor that can be seen here in the skull and in the right femur and pubic bone. So both X-ray showing multiple well-defined small-size osteolytic bony lesion involving the medulla of the right femur and the pubic bone, and also few in number are seen just in the lateral skull X-ray near the black arrow. This represents features of multiple myeloma. More specific sign for the shape of the lesions in the skull of patient having multiple myeloma is called raindrop sign. So in this X-ray, which is taken in AP and lateral view, we can see multiple small well-defined osteolytic lesions involving the skull vault. These lesions are usually near each other in size, so they are nearly uniform in size, and they are rather small in size also. This represents the features of the multiple myeloma. Sometimes we can put differential diagnosis, which is the metastasis to the skull, but usually the metastasis is showing larger sizes and they are not so equal or near each other in size. So this can be important description for both multiple myeloma and metastasis. In hematological diseases, we have example the thalassemia. The thalassemia, it is a hematological disease that affects the bone or the skeletal system in the following criteria. We have first of all the skull X-ray. We can notice thickening of the diploic space, as we can see that the vault of the skull here is speculated by multiple hair-like lines seen vertically oriented to the vault of the skull. This is called sun-ray speculation, which is related to the thalassemia. In the hand also, we suspect that there will be hyperproliferation in the area of the bone marrow. So we can see that the arrow is marking the metacarpals of the hand, and that's showing slightly expansile bony changes, and this represents changes of thalassemia. There is expansion of the metacarpals. You can notice them in the whole metacarpal bones. Also, in CT scan, this diploic space or hyperexpansion of the skull vault, especially in the frontal and in the occipital area, it's very clear in this bone image or bone window of CT scan, in which we can detect these thickening in the diploic spaces. Acromegaly is a growth hormonal abnormality, and we have changes in the skull X-ray that will be shown in this X-ray, which is a lateral X-ray of the skull, showing enlargement and thickening of the diploic space of the skull vault. Also, there is enlargement of the frontal airspace sinus, and on the area of the yellow star, there is a ballooning or enlargement of the pituitary fossa is well clearly seen. Other example of the acromegaly is shown in this lateral X-ray of the skull, in which we can see there is area of widening in the mandible angle, which is demarcated by the green spot. Also, prominent anterior chin, which is seen at the yellow arrow, and posteriorly there is a prominent occipital protuberance, which is seen demarcated by the red arrow. Congenital abnormality we should know about it is called achondroplasia. Achondroplasia, in fact, many features can be shown in the next slides. First of all, this lateral X-ray of a child which is a known case of achondroplasia, we can see that the abnormality is in the skull shape. The skull shape looks abnormal because the skull vault is enlarged and there is a small skull base. The green line showing us the area of the skull base, which is relatively small in regards to the other part of the skull. Other abnormality which is very prominent in the pelvis and also in the limbs of the child, we can see that here the area of the iliac bone, it looks abnormal. Normally it should be seen as nearly triangular shape, but here we can see that both iliac blades are enlarged and appear as square in shape, with also abnormal orientation of the acetabulum. We can see that there is a horizontal acetabular roof. Here we have another X-ray for the same condition. We can see that the abnormality is in the humerus and in the bones of the upper limbs as whole. We can see that the abnormality is that broadening of the bones and shortening in their length. So there is a short stature as a result. This plain X-ray of achondroplasia, there is an important sign which is called the interpedicular space. There is a space in between the pedicles of the vertebra, and normally the spaces is usually enlarged as we go from upside down, while here if you look to the yellow arrow, the marker is showing us that the interpedicular space is gradually narrowing or tapered in diameter to reach the area of the sacrum. فإذا نلاحظ أنه المسافة ما بين the two pedicles of each vertebra is decreased in this film, which is an important sign also seen in achondroplasia. Here we have another X-ray showing us the typical shape of the iliac bones. We can see there is enlargement of both iliac bones very clearly noted in this film, and also there is abnormal shape of the bone which looks shorter in length, broader in width, and we can see some little bowing of the shape as a whole. Rheumatoid hands or rheumatoid arthritis mainly seen in the hands. To start with, we have the right image of X-ray of the hand showing abnormal shape of the fingers because of the ulnar deviation, and we can see there is metacarpophalangeal abnormality in form of subluxation, also slightly erosion noted. In later stages of rheumatoid arthritis, we can see abnormal deformity of the distal phalanx, which is shown here in both little and index finger in form of what we call it boutonniere deformity. Also, on the image on the left, we can see that there is X-ray taken for the area in between the phalanx. We call it the interpharyngeal region or interpharyngeal joint. There is abnormal density shown by the red arrow, which represent the late changes that can be seen in the area of the bone in rheumatoid hands. We call it decrease in bone density or demineralization as shown in this image. While that is the image which is demarcated by the green arrow, we can see slightly preserved joint space and area of bone density. So the changes اللي ممكن نشوفها بالهاند تعتمد على الستيج and تعتمد على التشينجز حسب اللي تفرق من مريض إلى آخر ومن إكس راي إلى ثانية، ومو شرط نشوف كل التشينجز بنفس الفيلم، ممكن أن نشوف early changes وبالعكس ممكن نشوف the late changes or the deformity. Another plain X-ray of rheumatoid hands showing abnormality mainly noted in the area of the carpal bone because we cannot demarcate the whole carpal bone. That means there is a fusion of the carpal bones, which could be also seen in rheumatoid arthritis. And there is a metacarpophalangeal joint involvement mainly by erosion, which is noted more obviously on the right hand, demarcated by the star area. Also, deformity is noted in the right little finger, which is seen in the distal phalanx and showing also fusion of the interpharyngeal joint. The area of the styloid region also could be involved. As we can see on the small arrow, there is a soft tissue swelling and erosion in the ulnar styloid process. This plain X-ray shows us the classical appearance of changes that could be seen in rheumatoid arthritis. We have here the bone density is abnormal. We can see that there is generalized decrease in the bone density of the metacarpal and phalangeal bones. and there is erosion, which is well noted as you seen at the green marker. There is erosion in the most important site, which is the metacarpophalangeal joints. Also, you cannot clearly demarcate the carpal bones, so this represents area of fusion or erosions which could be seen in the carpal bones, and even mild soft tissue swelling at the region of the ulnar styloid process. So these are bilateral symmetrical changes which could be seen classically in the rheumatoid arthritis. In ankylosing spondylitis, which is a seronegative arthritis, we have early changes that is usually seen in the sacroiliac joint. And here I put two slides for you. On the right side we have the normal sacroiliac joint, and on the left side we have the ankylosing spondylitis changes. Normally the sacroiliac joint appear as a very thin lucent line in the both sides of the sacrum. So the triangular shape here, which is marking for the left sacroiliac joint, it is a very narrow or very thin lucent line. This is a normal one. While in ankylosing spondylitis there will be early changes in form of bone signal density changes like sclerosis. So on the image on the left side, which is ankylosing spondylitis, we can see the sclerosis on both sides of iliac bone, and the sacroiliac joint is not so clear, and this represents changes of sacroiliitis. And here we have a CT scan image taken in coronal sections for a demonstration of the sacroiliac joints. You can see in image A and B the changes of sclerosis, which is more obvious or more advanced in the image A, while in image B still there is preserved joint space. These changes represent sclerotic areas of sacroiliitis in ankylosing spondylitis. About the vertebral changes or spinal column changes of ankylosing spondylitis, we have early and late changes. In fact, in the lateral X-ray of the lumbosacral spine, we can see abnormal shape of vertebra, which is more towards the square shape. Normally, it should be rectangular, and there is a good amount of space in between the vertebra, while here we can notice that the shape of the vertebra is more toward the square shape, and this gives an impression of narrowing in the intervertebral disc spaces. And on the later stages or in advanced cases, we can detect calcification in the surrounding ligaments. So as you can see on the green arrow, there is a very dense midline structure. This is in fact a calcification of the posterior longitudinal ligament in a case of ankylosing spondylitis. In this slide, there is a specific sign for ankylosing spondylitis. We call it bumbo spine, in which the shape of the spine is wavy on both sides due to calcification of the posterior and surrounding other longitudinal ligaments, and this results in this shape of the spine just like one piece. And then we can also look for the sacroiliac joint. We cannot detect any space for the sacroiliac joint, and this means that there will be fusion on both sides and sacroiliitis. Common abnormality in the vertebral column is the spondylosis. Here we have example for the lumbar spondylosis, in which there is degenerative changes seen in the form of decreased or narrowing in the intervertebral disc space. مثل ما تلاحظون أنه المسافة بين الفقرات أصبحت very narrow. وأيضا هناك sclerosis in the end plate of vertebra. فإذا نشوف الدنسity الخاصة بالvertebra، نشوف أنه ال end plates of vertebra are more denser than the body of vertebra, and this represents degenerative spinal changes. Also, we can see a prominent bones anteriorly, which is noted in the lateral X-ray more prominent. This is called osteophytes, and they are marked by the red color in both views. So this represents the osteophytes. Sometimes, in certain cases, we can see a small area of gas within the degenerated disc, and this represents a vacuum phenomena which can be seen in osteoarthritis changes. In gout arthropathy, we have also another criteria. In this plain X-ray, you can detect there is abnormal erosion in the bones noted in the big toe. So the site is the big toe, and you can see that the yellow triangle is demarcating the region of the bony erosion, which is seen on the medial surface of the big toe, mainly the metatarsal and tarsal bones. Also, other joint is noted on the right side, which is the elbow joint. There is a big soft tissue swelling surrounding the elbow joint with multiple areas of small and variable size dense bodies noted within the soft tissue of the joint. This represents a calcified tophi related to the gout disease, which is represented by the star region. So, two criteria noted in gout: the type of the erosion, which is noted medially in a specific site, which is the big toe, and also we have the case of tophi in the elbow joint, which is very clearly noted in this image. Dislocation of hip joint, which is in fact called developmental dysplasia of hip joint, it's a very important subject, and the way to diagnosis represent to know the normal lines which is responsible for the normal pelvis or hip in both sides. So to start with the normal anatomical line, it is just an imaginary line shown here by the blue color. It is the Shenton line. This line is very helpful to detect the presence or absence of DDH. So this line should be drawn along the inferior border of the superior pubic ramus, and this line should be regular and smoothly seen along the inferior medial part of the proximal femur, just like this image. How we can draw this line? This will be the normal one. Another important line for the diagnosis of the DDH, we have a vertical line which is called Perkin line, drawn perpendicular and just from the lateral most part of the acetabular roof downward. Normally the epiphysis should be located medial to this Perkin line. Also we have the Highland-Rainier line, which is drawn horizontally, and the epiphysis should be located according to these two lines just in the inferior medial quadrant. This plain X-ray of pelvis shows that there is abnormality in the left hip joint. This is very clear because the Shenton line first is discontinuous, and because the epiphysis looks very small and lateral to the Perkin line. So you can compare between the left side, which is the abnormal, and the right side, which is the normal. We have here two examples. Examples A, in which we can see that there is a left DDH. This is because the abnormal shape of the left hip. If you try to draw the Shenton line, Perkin line, you can detect that the epiphysis is very small and it is at abnormal position, and even the Shenton line, it will be interruptedly drawn. So this is the left hip or left DDH, while in image B you can detect both hips are abnormal. If you try to draw the Shenton line or even Perkin line, you can detect there is abnormal site of the epiphysis, and even the Shenton line on both sides is interrupted. So this represents also bilateral DDH and even abnormal acetabulum. This is X-ray or plain X-ray of both hip joints in adults. You can see there is a long-standing right-sided DDH with false articulation. So the abnormal articulation is seen between the head of femur and area just superior to the acetabulum. So this is another advanced DDH. The last bone pathology is a process called avascular necrosis, or more correctly we name it as osteonecrosis. It is a term that is referred to the abnormal death or ischemic death of part of the bone. Any part of the bone could be affected, but we will concentrate on certain areas which are more prone for this pathology. So, in this abnormality, what we suspect? We suspect area of avascular tissue in the bone. So the bone, it will become devascularized, and after that there will be density changes in that part of the bone in form of low density, sometimes fragmentation of the bone, and sometimes as end result there may be a sclerosis of the bone. So we can see this story in the remaining slides. Example for the osteonecrosis is a common site in the children, which is the epiphysis of the femur head. Now we can see the right and left image are marking for the area of the abnormal epiphysis. So to start with, in the image on the right side, the area of the femoral neck is broadened or widened, as you can see the yellow line. So it is more wider than the right side. Also, there is focal area of fragmentation and abnormal growth plate, which is seen in the femoral head. So the shape of the femoral head is abnormal. It is fragmented and slightly flattened. Also, area of sclerotic changes is seen in the epiphysis. So the density of the epiphysis in the left side is more than on the right side, and this represents what was called Fibrous disease. On the image on the other side, we can see that there is a very clear flattening in the epiphysis and very clear widening in this region. So this represents a radiograph including stages of the Fibrous disease. Could be fragmentation, could be just area of flattening and sclerosis, and sometimes, as I said, there is a broadening in the area of the femur neck as shown in this image. Avascular necrosis also can affect the vertebral body. As you can see in these multiple thoracic vertebral bodies, there is abnormal shape because there is no rectangular shape of the vertebra. Instead, there is anterior wedging. They means they are anterior triangular shape of the vertebra. This is occur because of the same process, which is the osteonecrosis. There is a devascularization in this part of the epiphysis and results in the abnormal compression, and this if continue, this may result into deformity of the thoracic spine and in kyphosis. This is called Sherman disease. As you can see, this is an advanced case of osteochondritis of the spine, which is called Sherman disease. أحيانا الأوستيوكوندرايتس ديسيكانس ممكن أن تحصل في الني جوينت في منطقة الفيمورال كوندايل. في هذا السلايد خلينا صورة عن الام ار اي of the knee joint وخلينا اكس راي ايضا of the knee joint. الحقيقة الصورة very clear في الام ار اي. تلاحظون انه there is area of part of the bone which is separated from the original bone in the femoral condyle, and in the x-ray you can see slightly or very thin lucent line separating part of the femoral condyle medially from the original bone. In fact, this area represents area of osteochondritis dissecans of the knee joint, which is also due to the same process of osteonecrosis. Unate bone is also affected by the same mechanism of osteonecrosis. فمن الممكن أن يكون بالبداية there will be devascularization and fragmentation, sometimes even sclerosis. وهذا مثال على osteonecrosis of the lunate bone, which is very dense in this image, and you can see the marker just on the bone which is abnormal, and this disease is called knee book disease. In the foot, the navicular bone, which is shown here, is also susceptible to the same process. This disease is called Cochlear disease, and if we describe this plain X-ray, we can say this plain X-ray showing that there is abnormal, dense or abnormal bone which is seen just in the area of the foot. It is located in the navicular bone region, so this represents avascular necrosis, which is involving the navicular bone and called Cochlear disease. Another site is the tibial tuberosity. You can see in these films we have a lateral X-ray of the knee joint, and there is abnormal area which is fragmented and slightly area showing osteolytic lesions. This represents abnormal site involving the tuberosity of the tibia and called Osgood-Schlatter disease. That is osteonecrosis involving this type of the bone. This is just associated with sometimes thickening of the ligamentum patelli, which is connected to this region. Lastly, the same process but in the ankle. You can see that the arrow is marking for MRI and for X-ray, but for special part of talus, which is the articular superior surface of talus, there is a bone defect just slightly separated from the original bone, and this represents another types of osteochondritis dissecans, just like we described in the knee, for example. Here the same process but in the superior surface of talus.